Hello, I'm Nathan Loynes. This was prepared in 2023. The medical model is dead. Long live the medical model. This provocative title is not mine. It's the title of a journal article by Premal Shah and Deborah Mountain that was published in 2007. In 2007, Shah and Mountain published an article in the British Journal of Psychiatry entitled "The Medical Model is Dead. Long live the medical model." Now, this apparent contradiction in terms sort of gets to the heart of what their article is about, which is after the death of an existing model, a new, improved version of that model should sort of spring from the ashes like a phoenix and continue to make progress, drawing on the positive influences that the previous model has had. I know that's quite a confused set of metaphors. I hope it kind of makes sense, but I'm trying to convey what Shah and Mountain mean by the title of their article. They identify that critics and psychiatrists have often debated the medical model, with psychiatrists apologising, while critics, such as the anti-psychiatry movement, have been scathing. We'll look at some of those criticisms in a moment. Shah and Mountain recommend redefining the definition of the medical model to align more closely with modern medical practice, and furthermore, that the medical model should inhabit a space within a broader set of psychiatric principles, that is the biopsychosocial realm, which takes into account biology, psychology, and the social circumstances of an individual. I do recommend that you consult the article though, because you'll find more depth than I'm able to cover in this short video. So let's start with defining the model. The medical model has various definitions, but the Disabled People's Movement views it as based on a false notion of normality, focusing on what people with disabilities cannot do and provoking fear and patronising attitudes, often perpetuated by powerful doctors. So here we have one of the scathing critiques of the medical model, in that it has a very narrow it hinges on having a very narrow definition about what is normal, and anyone that fits outside that box needs to be cured, treated, changed in some ways so that they can be as close to normal as possible and participate. Shah and Mountain point out that the basis of the medical model has always been the Hippocratic or Hippocrates principle of first do no harm. And all medical practitioners, psychiatrists or otherwise, should hold this in the forefront of their mind when they're dealing with people, to not make things worse, to do any harm. This principle operates under the assumption that a doctor possesses particular knowledge and expertise, indicating that an intervention offers more benefit than harm. So we trust doctors because they have expertise and knowledgeable, and we trust them because they believe that at the bottom line they seek to help us. So how does this Hippocratic principle operate in contemporary healthcare practice? Well, doctors adhere to this practice, and it also aligns with patient expectations, as the era of relying solely on intuition or gut feelings in treatment has passed. Parental trust comes from the belief that doctors have expertise and they're basing their diagnosis and treatment plan on evidence. While some individuals may raise doubts about the extent to which daily medical practice is evidence-based, there is no compelling argument to discard evidence-based approaches in favour of faith or instinct alone. So Shah and Mountain here are saying that evidence-based practice is the best alternative that we have. Furthermore, in explaining contemporary healthcare practice, Shah and Mountain claim that checks and balances are in place, as well as patients being able to make choices. Medical practice is increasingly guided by established protocols, and there are legal repercussions for deviating from them. Patients prioritise the effectiveness and safety of treatments over their ideological origins, what works rather than what to believe in. And patients seek a comprehensive and unbiased perspective to make informed choices. So treatment isn't simply done to patients, they are participants in the process, so claim Shah and Mountain. Furthermore, the medical model evaluates treatments using a uniform approach, and this establishes rigor in terms of medical testing. Each treatment must support their approach with evidence rather than relying on ideology. It is unjust to assume that mind treatments are exempt from scrutiny or are inherently superior to others, more mundane medical treatments, let's say. Scrutiny is especially crucial when public funds are allocated to interventions, such as those in the National Health Service. And the medical model supports the expansion of both non-pharmacological and drug-based treatments based on evidence. So, what's the problem? The medical model in psychiatry often carries negative connotations, seen as paternalistic, inhumane, and reductionist, and we've seen these claims be made elsewhere. This perspective has influenced mental health organisations advocating for a departure from the medical model, leading to conflicts between politicians, professionals, and patients, all at the expense of medical progress and patient care. Some support for this view comes from within psychiatry itself. And as we've seen elsewhere, in the 1960s anti-psychiatry movement headed by R.D. Laing and Thomas Szasz, but also the recovery movement. But such diversity can lead to unproductive rivalry among therapies and agencies seeking recognition as the primary therapeutic approach. So it's a political struggle for dominance rather than effective patient care. Let's have a look at one of those criticisms that the medical model is biological and reductionist. There are views around that psychiatric drugs differ from those in other medical specialities, or the alternatives such as homeopathy. There's an assumption that psychosocial treatments, i.e. non-medicated, are risk-free, holistic, and the preferred treatments. And this overlooks that some psychological treatments can be harmful. However, biological explanations and treatments for diseases have reduced fear and stigma and increased understanding in other medical fields. Shah and Mountain conclude that psychosocial treatments may also complement drug therapies. So they're looking for a more holistic approach of which it's not an either or of psychosocial versus medical model or biomedical. Actually, the two can work in tandem in a more holistic therapy. Another criticism of the biomedical model is the power dynamic between doctors and patients. We'll explore this elsewhere in the work of Foucault and power. However, Shah and Mountain claim that the patient-doctor relationship is actually intricate, involving patients seeking help and making decisions about their treatments. They are not powerless. Therefore, patients actively participate in their healthcare, and their behaviours and expectations are not passive. And that patient empowerment doesn't involve rescuing patients from the medical model, but rather aiding them in making informed decisions. Therefore, Engel's psychosocial model complements the medical model rather than contradicting it, as it enhances patient engagement and understanding. Furthermore, Shah and Mountain propose the need for an evolving definition that incorporates modern medical neuroscience advances. A contemporary definition of the medical model should reflect medicine's fundamental ideals, i.e. do no harm, while acknowledging its limitations, i.e. that the medical model is not the sole cure-all for everything. Shah and Mountain proposed that the medical model is a process where doctors, informed by the best available evidence, offer advice, coordinate or provide interventions for health improvement. Furthermore, a modern definition of the medical model can continue to rely on the summary, does it work? If it does work, we should continue to use it. However, we've seen critique elsewhere that initially one might seem that a frontal lobotomy undertaken in the 1950s worked at curing a patient's depression. But is that actually the case? Are more side effects and problems caused that they're not initially apparent and might initially appear to be a cure? How do Shah and Mountain propose that we can take this new medical model forward? Well, that we should continue to gather high quality evidence, especially when determining the effectiveness of psychosocial treatments. And this is essential for bolstering psychiatry's credibility. In other words, testing and understanding results and treatments should be rigorous and essentially scientific. Informed psychiatrists using the medical model are well suited to challenge extreme Cartesian views, acknowledging that the medical approach may differ from other healthcare professionals. What this means is that often there is a tendency to continue to see the mind and body split in the Cartesian tradition, the tradition established by René Descartes in the 1600s. However, psychiatrists can try to mediate and remedy some of that extremity. We can take it forward by embracing developments in neuroscience that bridge the gap between the mind and brain and can bring rationality, specificity, and validity to interventions. So again, within a scientific paradigm. And psychiatrists are not just unidimensional pharmacologists and reductionists. Their training involves biological, social, and psychological treatments, making them specialists in the holistic biopsychosocial approach. And I think this is possibly the most interesting one, really, that Shah and Mountain relocate psychiatrists from not just being people who are drug pushers, seeking to push pills, but actually they have a holistic understanding of mental illness and will seek to look at a holistic range of factors, ranging from how the individual thinks to their social circumstances and if drugs might be the right option to complement a treatment plan. So in summary, Shah and Mountain make the case for the medical model, or some of the benefits. I guess that the medical model is dead, long live the medical model, could have alternatively be called don't throw the baby out with the bathwater. In other words, just because there are some problems with it, don't discount the whole thing. They recommend redefining the definition to align with modern medical practices. And they propose that psychiatrists leverage the medical model to enhance and legitimize biopsychosocial psychiatric medicine. As I said earlier, if you'd like to look at this topic in more detail, consult with the original article by Shah and Mountain, The Medical Model is Dead, Long Live the Medical Model.